Hey, this is Phil Weinberger, and we're back with another case discussion video. This is an endodontic case. So Dr. Garry Bey is an endodontist. He's got two locations, Rockland Endodontics in Pearl River, New York, and Northern Jersey Endodontics in Woodcliff Lake, New Jersey. It's got a pretty interesting case to go through, so let's just get right to it. Hey Gary, what's going on? Good to see you, man.
Great to see you. How you doing?
All good. Thanks for doing this. I appreciate it. Um, this will be good. So why don't you give a quick little intro so everyone kind of knows a little bit about your practice and what you're doing, lecturing and things like that. Just a quick little intro.
So I am a practicing endodontist. I have my main office in Pearl River, New York, and we have a satellite office in Woodcliff Lake, New Jersey. I've been in practice for many, many, many years, and I've estimated that I've done about 40,000 root canals.
A couple,
I have,
just a couple.
yeah, so I have some experience. I have lectured extensively, both nationally and internationally, and really enjoy sharing cases and knowledge with my colleagues.
Awesome. And you and I started out, has it been maybe 10 years or so when you first got first cone beam with the 9000 3D we started out with? Is that 10 years ago?
That was, I was thinking about it. I think it was 10 years ago when I finally jumped into using cone beam technology. And as I've told you in the past, the one regret that I have is that I didn't start using it earlier.
Yeah.
Because like any other technology, now that we have it, I couldn't even imagine practicing endodontics without it.
Yeah, exactly. I mean, if I had a nickel for every time I heard someone say that, it's really kind of amazing. So we've updated you to the 9600 a little while back. Any major differences that you see from the 9000 to the 9600?
There's a few major differences. One is the size of the screen is adjustable, and we like the 6x6 on most of our cases, as we can get a number of teeth. We never miss an apex. The scans
the field of view, when you say size of the screen, like the field of view? Got it.
Yes,
okay.
even though it's still a small field of view with limited radiation, it encompasses everything that we need. We never miss a scan. We get exactly what we need with not too much extra. And the resolution is incredible. It's absolutely in a different league than the early machine that we had, and that makes a world of difference for us.
Awesome. Okay. So when it comes to clinical applications, so like what clinical applications are you using it for? Are you taking it on everybody or more to specific applications?
Well, there's three main groups that I take scans for. Number one, for retreatments, we take basically a scan for every retreatment. I want to know if why it failed, if we can see a fracture, discern a fracture from the bone loss around a root, if there's an extra canal that was missed. So basically every retreatment gets a cone beam scan.
Okay.
The next category would be diagnosis. We find it extremely helpful, and as you know, Philip, the research shows that many periapical radiolucencies that don't show up on periapical radiographs are clear as day on a cone beam. So very frequently, and in endodontics, patients go to their general dentist. They have symptoms. A tooth can be positive to percussion. They get referred. They're put on antibiotics. They come back a week. They come to us a week later, and all their pain is gone. They're not percussion sensitive, and now diagnosis for us, even though there's a referral, becomes complex. So to confirm the diagnosis, we do take a cone beam scan, and very frequently patients are referred to us with an incomplete diagnosis, and the cone beam scan does solidify the diagnosis.
Okay.
And the third, which is also a tremendous advantage, is there are certain cases when we can't locate a canal during treatment.
Yeah.
Nowadays, in the past, we were guessing. We could take a periapical radiograph, but you didn't know the buccolingual aspect. Some of the time, it was hard to tell the mesiodistal aspect of where you were, and you were guessing as you drilled into the root. With cone beam technology, you get a three-dimensional view of where you are and where you need to be and how far you need to drill to get into that canal. It's priceless.
Yeah. Intraoperative scans is pretty commonplace for endo nowadays, for sure. Okay. Well, that's good. That's good. Well, you definitely have an interesting case to go over. So why don't we go ahead and jump into it and let's go through it.
Okay, so this is a case where a 62-year-old man came into our practice. He was referred for root canal treatment for tooth number 14. No diagnosis was requested. No CBCT was requested. The patient reported a history of discomfort and a history of swelling in the area of tooth number 14. And if you look at the radiograph, it does look like a darkened area around the mesiobuccal root of tooth number 14 with a deep restoration.
Yep.
And tooth number 13 is also encompassed in the area, but it would be very easy to think that the area was coming from tooth number 14, but also that it might be coming from tooth number 13. So there also clinically was a buccal fistula over the distal buccal root of tooth number 14.
Okay.
So we did our diagnostic tests, and tooth number 13 was negative to percussion, negative to cold, and negative to biting. Tooth number 14, also negative to all three tests. Tooth number 14 did test positive to the electric pulp tester, but you know that can be an inaccurate assessment of the vitality of a tooth, especially in a multi-rooted tooth. So we decided to take a CBCT. So let's take a look at the CBCT.
Okay.
So we took a cone beam scan, and if we look at the sagittal section on the right-hand part of the screen, and as we scroll through that, we can see that tooth number 13 is obviously encompassed in this radiolucency, but so are the buccal roots of tooth number 14. And I had mentioned before, which I thought was very interesting, the fistula was over the distal buccal root of 14. But if we look in the axial view, which is in the top left, and we move down, you can see that the cortical plate breaks here right by the distal buccal root of 14. So that makes sense. So the question is, which tooth is it? Is it still 13? Is it 14? And the deciding factor to me was looking at the palatal root. So we're going to go into the left side of the screen, the coronal view, and I want you to see something that I find very interesting. This here, if you look now, this is a clinical manifestation of periapical osteoperiostitis. And if you go to the maxillary sinusitis of endodontic origin AAE position statement, it states that the presence of apical periodontitis adjacent to the maxillary sinus cortical floor will often extend the sinus periosteum, displace it upward into the sinus, and subsequently induce a periosteal reaction that continues to deposit a thin layer of new bone on the inner periphery of the periosteum as it expands. And you can see that also on the sagittal view to the right. You can see that dome-shaped cortication going into the sinus. So if you look back here now on the coronal view, the one thing that really defined the diagnosis for me was that the periapical radiolucency stopped here on the buccal roots, and you can see the sinus floor. And here, the palatal root is still in bone. It's not involved at all in the periapical radiolucency. That, in conjunction with it testing positive, even though the fistula was over the distal buccal root, made me feel the diagnosis was tooth number 13 is the cause of the pathology. So going in and accessing into tooth number 13, of course, it was
non-vital.
So bottom line is, patient initially referred for root canal therapy on number 14. Obviously, after diagnosing, going through the cone beam, really the culprit's number 13.
Yes. So we treated tooth number 13, and when we
Okay.
went in and accessed into tooth number 13, it was completely non-vital. So I'll show you a picture of the an X-ray of the final radiograph, which is right here. And now
Gotcha.
we will have the patient back. This one, we have our patients come back in a 6-month follow-up. This particular patient I wanted to see sooner than that, so he'll be coming back in 3 months. But the key here is that we didn't access into the wrong tooth, and I certainly didn't want to access into tooth number 13, which is a distal
Yeah.
alignment of this bridge, and find out that that was vital. So I really relied on the cone beam for this diagnosis and seeing that that palatal root was not involved in the lesion. And I felt with a lesion of that size, the palatal root would have been involved if it was tooth number 14. I would bet dollars to donuts that this patient comes back in 3 months and that area is probably half the size, if not smaller.
Love it. No, listen, that was great. Excellent case presentation. Thank you again for doing this. That was awesome. I appreciate the time. Hopefully you enjoyed it.
I had a great time. It was a pleasure being able to share this with you and everyone who gets a chance to view this on YouTube.
And thank you, CZ, for all the technical help tonight. I appreciate that as well. I'm sure
Yes.
Gary does too.
CZ is my IT person. He's wonderful, and he was extremely valuable in this production.
Yeah. Perfect. Have a great night, Gary. Thanks again. All right. We'll see you soon. Thanks.
Thanks so much, Philip.